Uh, I am Dr. K Garg from the Department of Dermatology, Santosh Medical College and Hospital, Ghaziabad. Now, today's topic for discussion is vesiculobular disorders. Now, what we should know exactly about vesiculobular disorder is, first of all, these are classified into two types, genetic and acquired. In genetic, usually we discuss the epidermolysis bullosa. In acquired form, they are most common is the pemphigus, bullous pemphigoid, dermatitis epidermolysis, and CBDC. Now, another thing which we should know, the presence of lesions. Maybe it can be into granular layer, maybe spinous layer, maybe suprabasal layer, maybe basal layer. These are the layers of the skin, epidermis and dermis. Now, the classification, it can be junctional. Junctional, if you see junctional epidermolysis bullosa, bullous pemphigoid, and dermatology below basal lamina, it is epidermolysis bullosa dystrophica, epidermolysis bullosa equisica. Now, autoimmune bullous disorders, what they are? They are basically characterized by intraepidermal blistering at various levels in epidermis, disruption of intracellular dendritic substance, and due to an auto-antibody attack on the cellular adhesion protein leading to acantholysis. Basically, desmogleins are the most important thing. The various types of pemphigus are there, and vulgaris, veritans, policius, erythematosus, drug-induced paraneoplastic pemphigus. Now, what we see in pemphigus vulgaris, it is suprabasilar blister. Desmoglein 3 is involved. In pemphigus foliacea, where there is no oral lesion, only desmoglein 1 is involved. It is just below the stratum corneum in the granular layer. Now, another thing which is the thing what we see clinically, we see asymptomatic flaccid bullae on normal or erythematous skin, and usually sites involved are scalp, face, trunk, axilla, and groins. And what happens? The lesions usually starts from the oral mucosa, or the oral mucosa gets involved later on, and 100% oral mucosa is involved in case of pemphigus. Then they heal. They are flaccid blisters, and they heal by leaving behind a hyperpigmented macule. Now, the mucosal lesions are seen, as I told you, in all patients of the patient, all percentage of patients, and they are involved usually conjunctiva, pharynx, larynx, esophagus, urethra, vulva, and cervix. Now, there are two signs which we elicit while diagnosing the pemphigus, and most important sign is a Nikolsky sign, where a tensile force is applied and the peeling of the skin takes place. This indicates there is an intraepidermal lesion. Another sign is bulla spread sign. That is also not a Bosse sign. It is also positive, where the bulla spreads into the epidermis. The prognosis is poor without treatment, and the only thing is the systemic steroids, the mortality is more than 5 to 15%. Now, this is the demonstrable bulla spread sign, where we press the bulla, outmark the bulla, press from one side, and the bulla spread to other side. Then they are round giant smear cell, we see acantholytic cells. They are large round epidermal cells with a large nucleus, perinuclear halo, and peripheral condenses of cytoplasm. Now, if we see histopathologically, we see a suprabasal cliff. The cliff contains eosinophils, and it appears as if there is a dilapidated epidermis and a row of tombstones originating from the lower surface of the epidermis. Then acantholytic cells are also seen in the histopathology. Then another variant is, as I told you, pemphigus veritans, and here the vegetative lesions are seen. They are seen more on the flexures. Now, if you do immunofluorescence, intracellular, if you see direct immunofluorescence, we denote the IgG giving a fist-net appearance, and it is present in the epidermis. Now, pemphigus foliacea is a less severe form. Is a crusted lesion. You will get scaling, and it's mostly in seborrheic distribution. It involves the scalp, face, chest, and upper back, and oral mucosa is never involved. That's how it differentiates pemphigus vulgaris. Now, level of the split is very superficial. It's just below the stratum corneum, and as I told you, oral lesions are absent. Now, If you see acantholysis occurs in the granular layer and upper epidermis, pemphigus foliaceous antigen desmoglein 1 is involved. Now, there are other variants are there. Pemphigus erythematosa is a variant, and it's a variant of pemphigus erythematosus is a the other features which we see both pemphigus and lupus erythematosus in this pemphigus erythematosus, and they are sometimes you will face allele-like lesions over the face, and these lesions are similar to pemphigus foliaceus. Now, systemic steroid, what is the treatment? The progress I told you before invent of the steroid, people they used to die because of cachexia. Nowadays, what's happening? It's a systemic steroid in a dose of 2 to 3, high dose 2 to 3 milligram per kg body is given, is a drug of choice, and a pulse therapy, a bolus dose of the super pharmacological dose is given, and adjunct therapy like cytotoxic drugs, especially the azathioprine, cyclophosphamide, they are used. Now, what is actually pemphigus paranephrosis? It's one of the conditions which is very commonly, not very common, but it's uncommon, but is associated when we see severe oral lesions, especially painful oral and conjunctival lesions with erythematous blistering skin abscess in a patient with the underlying neoplasm. Neoplasm is usually leukemia, lymphoma, thyma or benign lymphoid tissues, and the PNP antigen, that is desmoplekin family, desmoglein 1 and 3 is positive. Now, another variant is called endemic pemphigus foliaceus fogosellum. It's a variant of pemphigus foliaceus and endemic to certain parts of South Africa and postulated by the site of bites of the black fly. Now, drug-induced pemphigus are also there with certain drugs like penicillamine, captopril, pyridine, penicillin, rifamycin can cause the pemphigus foliaceus-like lesions. Now, another thing is which we should know about other variants are sometimes pemphigus herpetiformis, like grouped lesions we can see IgA pemphigus where linear subcorneal pustular dermatology is seen. Now, juvenile pemphigus is occurring in children, and neonatal pemphigus is because of transplantal transfer of the maternal intercellular cements substance antibodies to the fetus. Blister resolves in 2 weeks. Now, another important thing is another condition called congenital Hailey-Hailey disease. It's especially what we say is a flux reagents they are involved, and this acantholysis takes place, and it's a defect in CA-dependent ATPase 2CA in the stomach endoplasmic reticulum. Autosomal dominant inheritance lesion precipitated by the friction and infection. Now, there is subcorneal supravasal cleavage, acantholysis, intercellular edema, deliberate brick wall, and then if you see these lesions, electron microscopy is very much diagnostic and considered with desmosomal adhesions, defect in the desmosomal adhesions, treated with anti-infective agents, light treatment and topical steroids. Now, what most important thing is now the second thing comes with the bullous pemphigus. What is bullous pemphigus? Bullous pemphigus is subdermal autosomal blistering disorder, more than 60 years of age, loss of structure in the basement membrane zone. Now, it's a large, tense, variably pruritic blisters with C3 and Ig deposition at basement membrane zone. And mucosal membrane is less, is 15 to 30% as compared to 100% in pemphigus vulgaris. Necrosis and bullous signs spread are negative. Now, blister formations in lamina lucida leading to a subepidermal vesicle containing eosinophils and neutrophils. That's how we differentiate from pemphigus vulgaris. And the antigen bullous pemphigus antigen which are involved are 230 kilodalton and 180 kilodalton. Now, if you see, there will be a continuous deposit of Ig, and C3 along the epidermal basement membrane. Now, what important thing is bullous pemphigus, we have to see it's a self-limiting drug. You don't require much severe high dose of treatment. For localized disease, topical steroids are used, and for diffuse disease, oral steroids are used. Now, we differentiate the tables as I told you: age, symptom, type of bullous lesion, site involved, healing of the lesion. That differentiate from pemphigus vulgaris to the bullous pemphigoid. Now, most important thing is the sign, which are Nikolsky sign, bullous pet sign, and they are positive in case of pemphigoid vulgaris, but they are absent in case of pemphigoid. Now, herpes gestationalis is an autoimmune disease in young woman occurs in the second trimester of pregnancy or within 1 week of the conception. Clinically, one side is with severe pruritus and rectal ills and plaques followed by bullous lesions in the perineum area. Because of environment and common recurrent subsequent pregnancies, preventively or OCPs. Now, dermatitis herpetitis formis another younger age group. Males, it is more than females. Intensely pruritic chronic recurrent papillovascular with severe acrogenesis are seen. Site involves are external aspect of the limb, elbows and knee, buttocks, natal clip, shoulder, upper back, face and scalp. Tendency of grouping of the lesions is there, and gluten sensitivity may be associated in these cases. So, if we see histopathologically, what we'll see at dermal papilla, we'll see the neutrophilic abscess, microabscess, there are collection of neutrophils. Now, if we do a immunofluorescence, there will be granular IgA deposit in normal appearing skin at papillary dermis. Now, dermatitis herpetitis is treated with dapsone in a dose of 2 to 3 mg per kg per day in divided dosing, and the drug of choice. Like it's a dramatic improvement, and sometimes gluten-free diet also play a role in control of the disease in some patients. Now, linear IgA dermatosis and chronic bullous dermatosis of childhood, they are the rare immune-mediated disease defined by homogeneous linear deposit of IgA at BMZ. Linear IgA most commonly appears in the 4th decade, and CBC commonly occurs in children less than 5 years old, and slightly female preponderance has been seen. Now, here also in chronic bullous dermatosis of childhood, it's an acquired autoimmune disease characterized by IgA antibody deposited dermatosis extremity are the common sites. Now, newer lesions appear around the old lesions, and they are called crown of jewels. That is very diagnostic, may not be diagnostic for this, but it is seen commonly in this chronic bullous dermatosis of childhood. Another thing is, we see here, if you do histopathology, we will see subepidermal bulla with collection of PMNS along the BMZ accumulating at the papillary tips. And if you do a direct immunofluorescence, a linear band of IgA at basement membrane zone will be seen. Now, most important thing is, what is the treatment? Spontaneous remission may occur with advancing age, but the dapsone is the drug of choice, and low dose steroid may be required in combination with the dapsone. Now, epidermal bullous acquisition is an acquired condition in old age, sometimes difficult to differentiate from bullous pemphigoid clinically, but IgG class of antibody directly against collagen 7 causes it. Collagen 7 is the major component of endocrinal fibers found in this subepidermal zone. Genetic mechanical bullous disorders are there, and they are epidermal bullosa. It can do 3 types: epidermal bullosa simplex, junctional epidermal bullosa, dystrophic epidermal bullosa. Now, bullous sympatico, sometimes we should differentiate. There is just an infective condition which should be differentiated from autoimmune disorders. So, hence, contact dermatitis also some cause blisters which should be differentiated. There I am talking about differential diagnosis. Then varicella and herpes zoster, they should be differentiated versus disorders. And of course, bullous FD also one of the confusing diagnosis sometimes. And thank you very much for patience listening about this. Thank you very much.